I have some slides as well. I have the little, but we can move forward on the. Great, thanks. I just have two goals for my short talk. Because one, just point out as the ethicist some things that I thought were really fascinating from the day and a half that we've already witnessed. This is Rich's ideas. Acceleration is not the goal. We have to optimize the data collection and get the right data at the right time. I just thought that was absolutely right. Don Harvey, my colleague, pointed out some of the risks of going too fast. And then I was about to, before I saw Steve's slides, I was going to make all this point in the next 4 slides, but I don't have to because Steve made them already so well. I said there's so much pressure for speed and access, but we can't give into that. And if I were going to put on the autonomy beneficence scale where I'd put drug development, I'd put it on the side of beneficence. I mean, I think we have to get the right data for the right patients and not put them at risk. One thing that hasn't been talked about a lot today that you know, you can't be an ethicist unless you talk about autonomy and consent. They'll take away your license. So, not that we have licenses, that's the other issue. Real-world data includes health apps. We talked about that not very much today. I think they're a great idea. MedWatch is a good idea, but it doesn't get used. We've got the data saying that people don't know about it, they don't use it. But we could have better ways to report patient AEs. We've got all these apps available now. I think it would be really important to start using that so we can get the real data. I know a lot of people have said that. But health apps have to have privacy warnings. The way they're used now, this data is shared pretty broadly, and the patients, I don't think, realize it when they click in their little data, that most of them don't have privacy policies. Even the ones who do share the data, and the patients aren't aware of this. This is just a quick study that was done in diabetes and showed the number of times that sensitive medical information was shared. Patients had no idea. So, I mean, that's just a concern. I think that we certainly need to use them. I think they are the future. I mean, you can't be a real person without a Fitbit, but, you know, we have to think about some of the issues. Consent for real-world data, I think retrospective data, we've got good things in place. I'm not worried about that. For the prospective pragmatic trials or for the registry trials that Steve pointed out, I think we do need consent, and I don't think we have to make this up. Right? We use broad consent for tissue banking. People walk in the door, they say, yeah, I use my leftover tissue for anything. I've done tons of study on this. Patients aren't concerned about it. They're willing to sign it. They don't have that many questions. The only really red flag that's come up in my own research and that of the NIH and Christine Grady and some of the other groups is that they're patients are worried about their tissue making money for somebody else. So that's the only thing that we've come up with is a real problem. I should point out, not all ethicists agree on this. They think that you can do these studies without consent. These are good ethicists. They're my friends. Rosamund Rhodes says that it's a public duty, and this data should just be available because of the love your neighbor principle. Jeff Bodkins, who's also a good friend of mine, says that absolutely this doing consent at the front door is a silly idea. It's a crazy thing. People don't understand what they're doing, and opt-out should be sufficient. So this is still a debate in the ethical field. But I think we need to move forward and make our consensus and come up with a solution. I love the ideas we've heard and we saw in the literature on seamless drug development on how we can improve consent. This comes both from Mark's work and from something he quoted today from Prowl in the New England Journal of Medicine, is that actually these seamless drug trials can have excellent consent paradigms. You pick the right people to enroll, and then you give a new consent for every cohort, make the risks and benefits clear, and share the early efficacy. The recommendations that are out there for consent on seamless drug development, I think, are really good. So I'm feeling really confident about that as far as the consent issue. Just a few comments.